And it meant all. Welcome, welcome, welcome.
Hello, everyone. Hope everyone is doing great today and enjoyed your Juneteenth weekend.
We're still allowing people in the room. We are recording. People are still joining us, so just give us a moment. We've had over 200 people register, so it's taking time. People are all coming in the room at once. While we're waiting to begin, everyone feel free to introduce yourself in the chat, your name, and any affiliations or organizations you're representing today. Oh, people are really, really ready for this discussion. We're so far, we just had 72 people jump in at once. So and that number is growing. So please feel free to interact in the chat box if you have questions, comments. Okay. As soon as it slows down with people coming into the room, then we'll jump in and get started.
We have people from North Carolina, Cleveland, Ohio is in the building, Oregon, and Arkansas.
If you're just joining us, please feel free to introduce yourself in the chat. You can put your name, pronouns, and organization that you represent, and any other little tidbit of information you want the rest of us to know. It's slowing down a little, so give people about another 30, 40 seconds to join the room. Once it slows down, we'll jump right in. People are really excited for this conversation. Great. All right. I think we're ready to jump in. And as more people come, I will admit them into the room. So thank you for joining PrEP in Black America. 1 second, more people coming in, trying to let them in at once. Okay. Thank you for joining PrEP in Black America for our first Mpox webinar. I am one of your facilitators. I am Michael Chansley, the Communications and Mobilization Manager with PrEP for All. And
Yes, thank you, everyone. My name is Abraham Johnson. I am the HIV Programs Manager for Treatment Action Group, and really excited for this conversation today.
And we are both members of the PrEP in Black America Coalition. This is our first public event since our summit a month and a day ago. So we just did our big PrEP in Black America Summit in New Orleans, Louisiana on the 19th of May. So really glad we got to take a few weeks off, but really glad to just jump right back in and start engaging our community again. This time we're actually engaging our community about Mpox. I think everybody knows a lot about what happened with Mpox last year. And we definitely have some panelists so that we can give everyone updates on what we did with Mpox, what we learned from Mpox, and how we're as a community we want to move forward. So before we get started, just want to, I don't like to call them ground rules. We're all adults, colleagues, peers, but just kind of some set the ground, just a few things. So this webinar is going to be recorded for those who could not attend. The recording will be available on YouTube sometime this week following the webinar. We have started everyone on mute. And if you accidentally come off of mute, please make sure you stay muted. Feel free to turn on your cameras. We want your presence, but not the background noise. Please use the comment bar to please use the comment bar if you need quick clarification or want to make a comment or have questions. And others in the chat will be able to help you out with that. 1 second. Also, please, if you haven't already, please sign in to the chat bar with your name and affiliation. So basically, since we have so many people on the call today, like I said, we have over 230 people registered. Best way for us to all communicate with each other is the chat bar. We will have a Q&A session after the panel discussion. If you want to ask a question of one of the panelists or of the facilitators or of anyone else on the call, please use the hand raise, which is located in a Zoom participant bar if you'd like to speak, or you can put those questions in the chat again. We will call on you to when we see your hand raised, we will then call on you. And that will be the time that you unmute your mic. And then after you ask your question or give your comment, you just request that you go ahead and put it on mute again. Thank you.
And Michael, quick thing, you talked a lot about PrEP in Black America. Do you mind just telling people what PrEP in Black America is if they don't know? I know we're here for a different cause, but there's some similar correlations.
Right. So, and I'm definitely going to drop the link. We have some information about PrEP in Black America on the website that I'll drop towards the end. But we did our first PrEP in Black America Summit, a coalition of Black HIV advocates. We got together and did. We wanted to address some of the dismal rates and challenges for accessing PrEP in the Black community. And we didn't want to just continue to talk about the barriers. We actually wanted to take a solution-oriented approach. So as we thought about doing either a webinar or maybe a series of publications, but we were like, no, we need to get everyone in a room together. We need to do something in person. We also had a virtual option. So we gathered a bunch of advocates to really take a solution-oriented approach to how we can get our community on PrEP. And it sparked so many discussions, both online and in person, that we held our second summit in New Orleans, Louisiana on May 19th at the Ashe Powerhouse. And we definitely expanded on some of the discussions from the first summit, as well as talking about how we can continue to work towards a federally funded national PrEP program to address some of those coverage barriers, as well as provider expansion and other issues that act as challenges for our community to get on PrEP. And we had a lot of lively discussions. We can't wait to share video recordings and the next report to come from that over the next several months. But because we've been working so much with community and helping to increase PrEP awareness and address challenges to PrEP, we thought it was definitely necessary to talk about Mpox as well, as that is something that the Black community we're seeing is being disproportionately impacted by, and definitely going to learn more about that from our amazing panel today.
Thanks, Michael. Sorry to put you on the spot.
No problem, no problem. Okay, so gonna go ahead and introduce, I'll go ahead and let Abraham introduce our panel. This is our agenda for today. So gonna pivot to Abraham for this.
Thank you, Michael. So first up, we have Brett Millett, who is Vice President at AMFAR, the Foundation for AIDS Research, and the Director of AMFAR's Public Policy Office. Mr. Millett is a former senior scientist with the Center for Disease Control and Prevention, as well as a former senior policy advisor in the White House Domestic Policy Council, where he helped author President Obama's original HIV/AIDS strategy. And next up, we have Dr. Kalexo Lakafani, who is an FXB Health and Human Rights Fellow. He is a public health researcher and activist who works in the global HIV response with a focus on sexual minority men in East and Southern Africa. He was previously a member of the Governing Council for the International AIDS Society and sits at the board of LVCT Health, a leading HIV service organization in Kenya. He also sits on the founding board of Global Black Gay Men Connect, an activist collective that aims to build power to stop discrimination and violence inflicted on Black gay men around the world. Kalexo has served on various working groups and committees that shape the global response to HIV. These include the Guideline Development Group and the first comprehensive World Health Organization guidelines for HIV prevention, diagnosis, treatment, and care for key populations, and the IAS Lancet Commission on the Future of Global Health and HIV Response. And last but not least, we have Victor Lee. Well, Rico Lee is a certified cardiac rhythm analyst with a strong background in healthcare and specialized expertise in cardiac rhythm analytics. Graduating from the School of Nursing in Tallahassee, Florida, Rico has honed his skills and knowledge in providing exceptional patient care. In addition to his cardiology qualifications, Rico earned his certification from the spot at the Worth Center for HIV Testing Training in 2018, demonstrating his commitment to comprehensive healthcare and addressing critical health issues. So thank you all for joining us, and I'm looking forward to the conversation. Welcome, everyone.
Okay, so I'm going to stop sharing my screen and going to pivot to Greg.
Hi, everybody. I'm not sure if you can see my screen or not. Hopefully you can. Terrific. Yes. Great. Thanks for the invitation to speak today and to give a quick update on the 2022 Mpox outbreak. Hope that everybody had a good Juneteenth weekend. I see that we're going right from the weekend into something really substantive. So I want to talk about, what took place last year during the Mpox outbreak, how it affected communities of color, and the degree to which this might even remain a lingering threat for communities of color. See. Now, the Mpox outbreak last year was fairly unusual. I mean, there have been many years where we've seen Mpox outbreaks, particularly in Western and Central African countries. But last year was the first year where we've seen significant spread in particularly Europe, the Americas, even in Australia, as compared to where we've seen it usually in endemic countries in Central and Western Africa. And we've seen that, the latest MPV outbreak is different than what we've seen and what we had in endemic countries. And we really should have known that this was going to be happening. There was definitely, some signs where, people were saying that they found that monkeypox has epidemic potential. That's from a paper that came out in 2012. Another paper that came out within the past decade saying that, the summary of recorded cases demonstrates an increase in the incidence of monkeypox cases in recent years, together with a broader geographical occurrence in endemic countries in Central and Western Africa. And there was another study that found that the monkeypox virus itself had accelerated around 50 mutations in DNA since its evolution. So there were signs there that we were going to have a massive outbreak. And when we did have the outbreak, we saw that the manifestations of monkeypox was actually very different than what we have traditionally seen for the past 50 years in Central and Western Africa, where, patients are turning up with what look like mosquito bites or pimples or ingrown hair hairs and not really these large pustules that, was all over the news last year in terms of what monkeypox looks like. And that borne out for the most part. This is a slide from a doctor in Barcelona who was taking a look at the difference between the 2022 outbreak and previous outbreaks. And the things that you could see really quickly here is that the previous outbreaks were really more 50-50 male-female, but last year it was overwhelmingly male. You also saw that there were
I think we may have lost Greg. Yes, I think he's part of like a Wi-Fi connection. We can give it
also said.
Okay. Sounds like he's coming back in. Greg, can you hear us?
He's on mute.
Okay, sorry, you got knocked out. So if you want to pull your slide back up.
Okay, is my slide back up?
Not yet.
Could you share the screen again?
Yeah, yeah. Have anything to share the screen with?
I think you need to make him a co-host again, Michael.
Sure.
Let's see, not seeing anything yet.
Okay, try now, Greg.
Okay. There we go. Okay, can everybody see the screen again?
Yes.
Okay, hold on, let me make sure that I can see it. Great. So I was going through, some of the differences between the traditional outbreak and what took place last year in the United States, and the differences in the manifestations of it, and the fact that there are viral roots that we've seen from a Nigerian outbreak that took place in 2017, 2018. And what was different about this outbreak is that it was primarily among men rather than men and women. And people suspected that it was among men who have sex with men in Nigeria. And why that's important is because we also see in Nigeria that you have higher rates as well for criminalization of LGBT individuals, where you can be actually sentenced for 10 years for public displays of affection, which is something that, of course, could affect what's going on in terms of these outbreaks. So in terms of the outbreak for the United States, about 30,000 cases that we had in the US. The outbreak was concentrated in the US, 42 deaths. We saw a precipitous decline in cases from about July of last year. A lot of that, thanks to the amazing efforts of Dimitri Daskalakis at the White House, as well as some of our public health officials, but also mainly because of the community itself. A lot of the cases actually peaked before there was a substantial vaccine rollout, and we could see that the community actually pulled back and really educated one another in what was taking place in terms of the outbreak. Unfortunately, now when you take a look at what's taking place with monkeypox, the Americas really remain the area of the world that is still the most impacted, with most of the cases taking place in America, and at least recently, most of the deaths have also been taking place in the Americas as well: Guatemala, Honduras, Mexico, and the United States, with some possible underreporting in some other regions of the world. The other thing that is really important, though, from the outbreak of last year is not just the fact that it occurred primarily among men who have sex with men, and men in general, 95%, but the CDC also found that African Americans represented 33% of those with Mpox, and Latino men were 31% of those with Mpox. So collectively, over 60% of those cases were taking place among men of color. So this brings me to the whole issue of Mpox inequities in the US and what we saw and what it kind of means for us as we move forward. The main inequity that we saw that's very different from the endemic outbreak is the fact that it primarily took place among men. And this is, Mpox cases that was compiled by CDC by age and gender. And what you can see is that it doesn't matter which age cohort that you're in. You see these dark blue bars, which is primarily, cases that are taking place among men as compared to women or trans groups. It doesn't mean that we didn't have an outbreak among women or that something did not take place among women. And I was happy to see that CDC reported data among cisgender women and pregnant women during the outbreak of last year. And the thing that you could see with those arrows pretty clearly is that among those women, about 800 of them, that the outbreak was concentrated again among people of color, women of color, where we saw that African-American women comprised about 43% of those who were diagnosed with monkeypox among women. Latinas were about 23%. And then you can see really clearly too that among those who are pregnant and diagnosed with monkeypox, that 71% of those were African American women. And why that's important is because you have some really dire consequences like stillbirth, et cetera, among those women who are pregnant and also diagnosed with monkeypox. So this is not just an outbreak that affected MSM of color and men of color, but also women of color as well. And then also globally, we found some differences as well among women globally, where you see that Latinx women and Black women were disproportionately affected by monkeypox, whether they were cisgender women or trans women. And then we also see as well that particularly among trans women, about 50% of those who were diagnosed with monkeypox were living with HIV. And we also saw that among trans women as well, that they were diagnosed, confirmed with a monkeypox infection through CPR, through PCR. 85% as compared to 99% among cisgender women. And why you see that difference is probably an artifact of the types of care that trans women get. Trans populations are far less likely to be engaged in care, to get care. And it doesn't surprise me that we see differences there compared to cisgender women. The other data that CDC released, and CDC has been releasing a lot of really incredible data, a sort of a post-mortem of the outbreak last year, was where the outbreak was concentrated. And you can see really clearly here that either by gender or by race ethnicity, that the outbreak was really concentrated in large central and urban areas of the United States and not as much in rural areas. But it doesn't matter if it was in an urban area or a rural area where you see that most of those individuals who were diagnosed with monkeypox and new monkeypox cases were among men. And then new cases of Mpox also were really concentrated among Black populations as well as Latinos. And it didn't matter which area of the country by urbanicity that they were coming from. The other thing that we see too is that, earlier on in the epidemic, there was a figure about 35 to 40% of populations that were diagnosed with monkeypox were HIV positive. And you see this in data not only globally, but also data that was coming in from the United States and CDC, about 41% of those diagnoses among people living with HIV, which I think had many of us afraid because we knew that what that would mean is that we would see disproportionate impact in communities of color, particularly men of color. And that's exactly what we saw, very early on during the outbreak, where they were taking a look at HIV positive men who were diagnosed with monkeypox by race and ethnicity. And what they found is that a quarter of Asian men diagnosed with monkeypox were HIV positive. 28% or a third of white men diagnosed with monkeypox were HIV positive. 41% or 4 in 10 Latino men diagnosed with monkeypox are HIV positive, and 6 in 10 Black men at one point who were diagnosed with monkeypox were HIV positive. So we saw that even though that monkeypox had about 40% overall of people who were diagnosed were HIV positive, that the ratio of people who are HIV positive was greater in communities of color. Very early on too, there were a lot of data showing that monkeypox rates and the way that it manifested was really not that difference between those people who are HIV positive and those people who are HIV negative. There was also data that came out during the International AIDS Conference in Montreal last year showing that there's really no difference in terms of monkeypox vaccine efficacy between HIV positive and HIV negative individuals But I think a lot of us were asking was, well, which HIV positive individuals were you measuring? Are these HIV positive individuals who are in care and immunosuppressed or not? And what became very clear is that these were individuals who were immunosuppressed and in care. And why that is important is because, when it comes to Black populations, we are far less likely to be immunosuppressed compared to whites and are HIV positive, and we're less likely to have sustained viral suppression, whether or not we're male, female, youth, MSM, or IDU, compared to whites. And that leads to more dire consequences for monkeypox. And that's certainly something that we saw. Last year, the first case that we saw that of uncontrolled HIV and monkeypox was among a man who was in Germany. Within 3 days, you saw his nasal area progress to necrosis, is what you can see here, where it was starting to actually fall off. And he was diagnosed simultaneously with monkeypox, as well as with HIV infection and syphilis. And this is really where we started to get a better indication of these syndemics, these interacting syndemics, overlapping epidemics, and how it really exacerbated what we saw with monkeypox, and how severity of monkeypox infection in the presence of severe immunosuppression and untreated HIV infection. And unfortunately, that's what CDC found by the end of the monkeypox outbreak of last year, is that they found there was really an outbreak among men of color, particularly gay men of color, and particularly gay men of color who had HIV and were not immunosuppressed. So 95% of the deaths that we saw last year were among cisgender men. 87% of the deaths from monkeypox in the US were among Black men. 94% of the deaths were among people who were HIV positive. And then in a subset of a group of people where they actually had additional information in terms of immunosuppression, 96% of the deaths were among those people who did not have, who were not virally suppressed. And then 8% of them, a small number, were actually vaccinated for monkeypox. Now, one of the things that we see with the monkeypox outbreak, too, was something that was mirrored with COVID-19, where we saw that there were a lot of Black and Latino people who suffered from financial consequences because of the COVID-19 pandemic, disproportionately. And you saw the same thing as well with monkeypox, with some of the rules about self-isolating for a couple of weeks, that it was leaving particularly working class people out, people who were living paycheck to paycheck, who couldn't afford to be out for that period of time, and primarily in communities of color, and something that I think many of us were really worried about. And it was not just communities of color. This is something that they were seeing all over. In Europe, there was actually a survey where they're looking at among those individuals in the Netherlands who were diagnosed with monkeypox, and over half of the men said they had absolutely no intention to self-isolate after diagnoses, that they had to get to work, that they couldn't afford not to get to work, and that they were just going to cover their bandages and move on. The thing, though, that I think was really important to see from CDC was the degree to which this vaccine worked, and worked rather well. I know that there was a lot of people who were worried about the differences between subcutaneous vaccines versus intradermal vaccines, and how that changed when we particularly saw greater rates among men of color. But it really didn't matter. You see these data from CDC that whether or not it's a subcutaneous vaccine, this is something where they actually stick the needle underneath your skin, to the intradermal, which is sort of the cells in between your skin, that you still had these very high rates of full vaccination and efficacy of the vaccine. And those people who are vaccinated with a mixture of subcutaneous or intradermal, still incredibly high vaccination rates, efficacy. Partial vaccination was actually really high as well. It didn't matter which way that you received it, that you had 77 to 80% efficacy for partial vaccination. And even among people who were immunocompetent, if you're HIV positive, immunocompetent, and partial vaccination, it was still 72%. So not that different from people who were not HIV positive. However, you do see, in terms of vaccination, that for those people who are immunocompromised, that was only about 50% effective, which is still good, but not as optimal as compared to other groups. And then, of course, we saw, unfortunately, many differences in terms of vaccine inequities by race and ethnicity in the United States. So even though Black, MSM, Latino men, and white men were about 30% roughly of the monkeypox cases, in terms of those who got at least one dose of vaccine, it was only about 10, 11% of Black men, only about 20% of Latino men. as compared to 50% of white men. Same thing for those who got 2 doses of vaccine. It was only about 10% of Black men, about 20% of Latino men, and then again, a little bit over 50% of white men. And why this is incredibly important, and these are from CDC data as well, and an MMWR that they released, is that you could see that as time went on between May and December of last year, and as these vaccinations stretched on, that we actually began to see differences in monkeypox incidence by race and ethnicity. So as the vaccine became available, you saw that the incidence became more concentrated among Black and Latino men as time went on, where the incidence rates really just increased in our communities, primarily because mostly white gay men were getting the vaccine. And that's part of the inequities where it made it mainly a Black and Latino disease, just the way that COVID-19 had become a Black and Latino disease at some point. Something else I want to talk about very quickly as well is ratio prevention innovation versus need. This is something that Patrick Sullivan's group came up with for PrEP, which is a really ingenious way of trying to figure out the degree to which we're getting PrEP into the communities that need it the most. And basically what you can see here is that PrEP to need in the South is about 3, which means that there's only 3 PrEP users for every new HIV diagnosis in the South, as compared to the Northeast, where there are about 8 PrEP users per every HIV diagnosis in the Northeast. Dimitri and CDC did something that was really ingenious, where they looked at PrEP to need ratio by race and ethnicity, and they looked at it over time. And these are data from AIDSview, where you can see that PrEP to need is still lowest among communities of color, where there's just fewer numbers of us who are on PrEP for every diagnosis as compared to whites. But the CDC released data where they're looking at PrEP to need by Mpox vaccinations. And what you could see is that these diagrams look very similar, where the PrEP to need ratio is highest among whites, whereas there's more whites who are getting vaccinated for monkeypox as compared to every monkeypox diagnosis, as compared to what you're seeing for Blacks and Latinos, where there are far fewer of us who are getting vaccinated, even over time, and as compared to each monkeypox diagnosis. So it was just interesting to see how these disparities persist no matter what disease you're talking about, from monkeypox to HIV. That access to these new innovations are unfortunately something that's really lacking and that we have to get better at in terms of distributions among communities of color. CDC very briefly had information on treatment for monkeypox or TPOX treatment. And basically you found a lot of the same things that I was discussing beforehand, that white men are a smaller proportion of Mpox cases, about 30%, but we're more likely to get treatment for TPOX. Latino men were less likely to get to treatment for TPOX, and the same thing for Black men who have sex with men as well. So again, you know, just this whole issue of some of these disparities being concentrated in communities of color. Some of the things that I wanted to get to that's a little bit different than what we saw last year is, what does this mean now? And I think what this means now is that we still have these inequities that are taking place abroad that could affect the monkeypox epidemic here in the United States. So one of the biggest inequities, of course, is, you know, access to prevention and treatment for monkeypox in the global South, where you see in Democratic Republic of Congo, Nigeria, and many other places, where they still don't have access to Mpox testing. They don't have access to Mpox vaccines as they did in the West. And this has some real life implications. One of the implications is the fact that if you don't have access to these vaccines and medications, is that you're starting to see more deaths that are taking place in Central Africa as well as Western Africa compared to what the monkeypox outbreak in other countries. So despite the fact that the United States, Britain, Canada, and other countries had a greater proportion of Mpox cases, the number of deaths were actually higher in endemic countries in Africa, because they didn't have access to many of these life-saving medications as well as prevention. And that's something that I think is going to be problematic and could come back to haunt us. And I showed these data beforehand about this Mpox outbreak that took place in Nigeria that was primarily among men, primarily, we believe, particularly among men who have sex with men in a country that criminalizes homosexuality. What does this mean if we have Mpox outbreaks or even HIV and other outbreaks in other countries, such as Uganda? What took place in Uganda over the past month in criminalizing gay and bisexual men and LGBT populations with death penalty for those who transmit HIV and 20 years in prison for those who are caught or engaging in homosexual behavior. And we are already starting to see some manifestations of that. There's already reports from clinics, PEPFAR clinics that have done work in Uganda for years, where they're seeing fewer people who are coming in for their HIV medications since this bill was introduced. Medical officials are reluctant to provide services to gay patients because they don't want to be accused of defending or promoting homosexuality. And essentially, you have this whole community that's going to be left in a lurch. And what's going to happen is that you're going to see greater rates of HIV infection. You might also see greater rates of people who might be getting Mpox and not coming in for any type of treatment or even a diagnosis. And there's real ramifications of this. There was a paper that I was on with colleagues from Johns Hopkins. It got actually a significant amount of press earlier this year, where they're looking at African countries that criminalize against homosexuality versus those that don't criminalize. And they found that those countries that criminalize against homosexuality had HIV rates among gay men that were 5 times greater as compared to those countries that do not criminalize. And those countries that had recent prosecutions for people who are LGBT had HIV rates that were 12 times higher as compared to those countries that don't criminalize. So there's real ramifications for this whole issue of criminalization. And we also have ramifications for it here domestically, because we know that homophobia is also associated with sexual health. And this is a paper that I was lucky to be on with Billy Jeffries. There's a meta-analysis that we all worked on for several years that was published last year, where we're looking across different studies looking at homophobia and its effects on health outcomes for gay and bisexual men. And basically what we found is that homophobia was associated with a 33% greater increase in sexual risk behavior among men who have sex with men, a 34% increase in greater risk of diagnosed HIV infection among men who have sex with men, and an increase in poor engagement in HIV care continuum among HIV positive men. So 2 times more likely to be not engaged in the HIV care continuum if you experience homophobia and if you're HIV positive. So it's not just these effects that we're seeing globally, but we see some of these effects on health outcomes domestically. And that's something that really is a reason why Mpox still remains a threat for many of us in the United States. Beyond the issue of criminalization, part of the reason why it still remains a threat is the connection between Mpox and recent STD, where CDC released data last year showing that 40% of those who had an STD in the past year were also diagnosed with monkeypox during the last outbreak. And why I think that that's important is because there are these reports that are coming up among people who had previously had monkeypox who are getting monkeypox again. They're getting a recurrent case of monkeypox again. And one of the things that you see in all these reports among people who are getting monkeypox 3, 6, even 9 months after their first case is that they had an STI, such as chlamydia, herpes simplex, gonorrhea, etc., including a recent case that was just published in The Lancet of 2 men who I believe in England, where they were recently diagnosed with chlamydia, gonorrhea, as well as Mpox. So we're seeing this association between recent STI and not having Mpox once, but twice. And that's something that I think we all have to keep an eye on. And why we have to keep an eye on it is the distribution of STIs in the United States by race and ethnicity. STIs are concentrated in Black and Latino communities in the US as compared to whites. And this is something that can complicate what we might see in terms of any resurgence of Mpox, particularly if we have lower vaccination rates, as I showed you beforehand for the Mpox vaccine. And this is something that we've seen in a lot of data. Back in 2007, colleagues and I published a meta-analysis showing that for Black gay men, that across studies, we are far more likely to be diagnosed with an STD, even though we engage in comparable risk behavior and actually have fewer sex partners compared to white gay men. That's not just from 2007. Data from 2022 is finding exactly the same thing, that we see higher rates of STIs among Black gay men who are not being diagnosed by their healthcare providers. If we see these high rates of STIs, this is something that can be complicated in terms of getting a new diagnosis of monkeypox. And then, of course, many of you have already heard about these clusters of individuals who have already been vaccinated, who are getting monkeypox. So the first time that we saw this earlier this year was in France, where they found that 60% of people had a new monkeypox diagnosis, but these were people who are already fully vaccinated. We actually saw the same thing in the United Kingdom in April, where there were 10 infections that were diagnosed between April 30th and 25th, and they found about half of those were people who were already vaccinated. Then, of course, we've seen what took place in Chicago among individuals who were previously vaccinated, where they found that, you know, a good proportion of those individuals also were people who were previously vaccinated. And then when you looked at the confirmed cases of monkeypox for those individuals where they had race and ethnicity in Chicago, you found that 15% were non-Hispanic Black men and 15% were Asian men. So we see that, you know, men of color were also a part of that impact of what was taking place in Chicago. The last couple of slides I want to talk about is, you know, the risk of an Mpox resurgence in the United States. And these are from data from the CDC, basically showing that only 23% of those at risk for monkeypox have been fully vaccinated. And the fact that, you know, there are many parts of the country where, you know, there's a greater than 35% risk of Mpox. We don't have enough people who are being vaccinated in different parts of the country. And this was something that CDC had published along with that, where you basically find that if you have 100% immunity, vaccinations for monkeypox, that you have very low probability of an outbreak, as compared to those places where you see maybe 20% of people who are vaccinated or some immunity, but you see huge opportunities for an outbreak, as much as 60%. This is something that we should be thinking about and worried about, particularly in those cities and in those states where we see large Black or Latino populations. So these are data from CDC showing that in Alabama, large Black population, of course, only 12% have one dose, 7% are fully vaccinated with both doses. Same thing in Arkansas, same thing that we're seeing in Florida and Georgia, Mississippi, where you're seeing really low numbers of people who are fully vaccinated. Thankfully, in California, where there's a large Latino population, we do see a greater number of people who've had at least one dose of the vaccine, if not 2 doses of the vaccine. In those places where we know that's concentrated among communities of color, including here in Washington, D.C., we seem to be doing very well in terms of 96% of people who have 1 dose of the vaccine and 2/3, 67% having 2 doses of the vaccine. Philadelphia can probably do better. Puerto Rico is far behind in really making sure that we have you know, communities of color and those who are fully vaccinated for monkeypox. The other thing that I think we need to worry about that is a question that is perhaps lingering is the degree to which people living with HIV are getting vaccinated at the same rate of those people who are not living with HIV, and some of the race and ethnicity differences that we see there. This is from a study that CDC published from New York City Department of Health, where they were looking at COVID-19 vaccine, and they found that people living with HIV in New York City were less likely to have the COVID-19 vaccine fully vaccinated for it, or at least 1 dose, as compared to those who are not HIV positive. And then, of course, you see these racial differences where African Americans living with HIV, Latinos living with HIV, American Indians living with HIV had very low rates of COVID-19 vaccinations. We still have to figure out whether or not that's actually taking place here in the United States as well. We already saw the data from CDC that among people living with HIV that had very high rates of monkeypox, that a lot of them were African American, and that we saw very low viral suppression. We need to make sure that we get at least 1 or 2 doses into as many people of color living with HIV as possible of the monkeypox vaccine. The other thing that I think we should all be worried about is, you know, what are the long-term effects of monkeypox and of these multiple epidemics? So for HIV, sort of the long-term effect of HIV, of course, is cardiovascular disease. We see that in study after study for people living with HIV, that we have greater rates of cardiovascular disease as compared to people who are HIV negative. Same thing for COVID-19. One of the biggest things that we see for COVID-19 is that people who've had COVID-19 over the long term report greater heart problems or even brain problems as compared to people who did not get COVID-19. And we're starting to see the same thing with monkeypox as well, where monkeypox has the potential to cause heart problems. So in communities such as Black communities, where we are more likely to get HIV, we were more likely to get COVID-19, and then more likely to get monkeypox, what are the long-term consequences of these 3 diseases on our long-term health in our community? And with that, I wanted to thank you for allowing me to present. Looking forward to hearing from my other two colleagues and any questions that people might have. Thanks again.
Thank you so much, Greg. That was great. I'll hold questions for the Q&A section, and we can move on with Calexo's presentation.
Okay, give me 1 second to pull that up. And while we are pulling that presentation up, I would like to give a quick plug. Oh, it's up already.
Yeah, I'm doing it off my own machine. Sorry, I didn't say that.
Just again, want to thank Greg, and just right now do want to make a quick plug that PrEP for All will be, with support from AMFAR, PrEP for All will be launching a survey within the next several days, just about people's kind of getting asking people questions about the previous Mpox response and some things that we can do better as we continue to move forward. So you will be getting that. If you registered for the webinar, you will be getting that within the next few days. Also, if you would like to do a personal interview, all responses will be confidential and anonymous. So, but if you would like to do a one-on-one interview, you can email me at michael@prepforall.org. And we are looking at people who are have either worked on an Mpox response or members of communities impacted by the Mpox response. So again, you can email me at michael@prepforall.org if you have any questions about that. And I'll turn it over to Dr. Calexo.
Thank you so much, Michael, and thank you for the kind invitation. Excuse me. I want to talk a little bit about, well, let me say, when the initial outbreaks happened, one of the things that we heard a lot is that an explanation for the disparity with respect to sexual orientation, in other words, an explanation for why there's so many gay men who had monkeypox, was that it's because of the sexual networks that gay people kind of live in. So one of the things that we wanted to do immediately was to measure the networks, because even though we were using networks as an explanation, we didn't actually have much network data to go off with respect to monkeypox. So this study that I'm going to present was kind of a response to the question of how do the networks help to explain the pattern of the epidemic. And part of the study was also making sure that the people who guide the study look like the people who are affected by the epidemic. So we invited anyone who wanted to join us in the study team to join as an investigator. There were no volunteers for our study. And among the co-investigators were queer and trans people, mostly in New York, with a fair kind of representation of people of color and Black people particularly. The name of the study was MPX NYC, and we had put quite a lot of effort into making sure that because we were trying to do a study rapidly, we were trying to kind of get people to engage with the study quickly. We invested quite a bit of effort into generating materials that look beautiful and that kind of play with ideas around sex. So we used this campaign with emojis and kind of with this slogan that you see on the right. The way we came, an important part of this story is that we even though it was a very quick study, we consulted pretty seriously on major aspects of the study, including what it looks like. So we had briefed a marketing agency to come up with a set of kind of a campaign for us. And they gave us a few options that you see over here. And we discussed those options and came to kind of a final design in consultation with community members. And part of what happened is that while we set up a regular call for the study in order to consult with folks who work in the space, who work in LGBT health, we ended up, by setting up that space, we realized the participants in that space let us know that there weren't spaces that were specific for monkeypox at that time, that community-based organizations and activists and other interested people could come to speak about their own organization's experiences of Mpox. So we ended up having this weekly call, which went from a consultation call to a coordination forum for whoever wanted to join the call. And out of that came a few kind of products which were very useful and did have impact in the response. So people who were part of that call ended up making a vaccine locator, for example, because it was really difficult to know when and how to get vaccine. We did some policy briefs, then there's some educational material for our community. And we also had to kind of raise funds to pay for the survey and to pay for the marketing campaign. And these are all the folks who chipped in one way or another. It was pretty difficult to kind of mobilize funding at that speed for a study like this. And so we're grateful to all those folks who really stepped up quickly. AMFAR was actually the first to kind of agree to give us funding, and PrEP for All graciously has held the finance and logistics of the study. And what we are now working on with the city of New York and thinking with other people is how to take this process that we went through to stand the study up and learn from it and use those learnings to prepare for future outbreaks that are coming, and even to guide how we intervene on HIV, on PrEP, on issues that we struggle with that create disparities in access to resources. So broadly speaking, we kind of think of a response, a community response to something like this as having 4 components. One is consultation. One is resourcing to figure out how to fund the effort, because we do need resources to get these things off the ground. The actual surveillance, so answering questions that are going to help you to respond. And for us particularly, we're interested in asking questions that are going to help us figure out where to put vaccine, because when we started the survey, we knew that there wasn't enough vaccine for everyone that needed to get vaccinated. And this was before the dose splitting strategy was kind of taken on. And then finally, it was important for us to also have some kind of coordination mechanism in the form of that call that I just spoke about earlier, because what we found is that the things that were needed right in that moment as the Mpox outbreak was unfolding were not contained by any single organization or individual. It was actually necessary to have multiple organizations who have different strengths and capacity to talk to one another and figure out how to respond to this new threat, which was not covered by any of their current programming. So that also is an important aspect of the response. And of course, this effort, the structure of the effort, the way that we did things doesn't come from nowhere. It comes from a lot of experience, particularly with me, in global HIV spaces. And the things we did kind of follow the mold of activists that have worked in that space for a long time. So the emphasis on consultation, on bringing different organizations together, and on making sure that civil society has the biggest voice in the room, and that we don't give civil society kind of just tokenistic participation in this process. So this is all to say the response is important in that it helps us to think through what to do in the future. And we're currently working on kind of learning from this and making sure that we don't start from the same place again the next time an outbreak like this happens. Okay, so the study itself is about networks and space and sex. So we wanted to understand where people are having sex, where people live, particularly group sex, because that's where, that was the setting in which a lot of the transmission was reported to be happening at that time. So we created a survey instrument specifically for the study. And what's different about the survey instrument is that it asks participants, it's anonymous, so you don't have to give information that might identify you if someone got a hold of our data set. And even though it's anonymous, there was a way for participants to indicate where they live. So maybe someone lives over there. and where they've had group sex in the city. And the reason, and then for every place that they kind of indicated. So you tap on the map and then these questions come up about what kind of place it was and whether you had sex there or not. So the data that I'm gonna present now come from this part of the survey instrument, which helps us to understand how to intervene. Okay, so the data itself, there were about 1,500 respondents. 40% of them said they'd had group sex or kind of extended physical contact in the past 4 weeks in a congregate setting. And of those 40% of 1,500 people, they gave us 700 places at which they were in physical contact with others or had group sex. So this analysis is about those 700 places. Some insights from this data. And I should say, so this is both retrospective, we're showing you what happened and thinking through how we can use information like this in the future, how we can design studies like this in the future. But at the time we were collecting data, we were already sharing it with the City of New York, so guiding their outreach activities so that they kind of went to some of the places that we indicated were important places to have vaccination in through the study. So the data have already been used, in other words. Okay, so 5 insights. One is that whereas usually when an outbreak like this happens, the first place I think that is natural to intervene is places where people have group sex and that are public places. So the Eagle, the Cock, bars where bars and bathhouses and places where people have sex on site. What we found is that 60% of the places that our participants indicated they had group sex were not public venues, they were private residences. So a strategy that only goes after public venues when an outbreak like this happens is going to miss most of the group sex that happens. This doesn't mean that you have to cover the entire city as intensely because residences are not evenly distributed across the city. There are places where there are more queer and trans people than other places. And in our study, we found that most people were kind of in this area, which includes Hell's Kitchen, Chelsea, which includes places which are known as kind of queer neighborhoods. But it wasn't even for everyone. And this is especially important in kind of thinking about how to deal with disparities. So Black people tended to cluster in slightly different places than Latinx people, than white people. So again, if you use just these maps to intervene, you have to pay attention to how specific subgroups have different kind of maps that would inform the interventions. Okay, the third point is that you can also think about the city as a network. So this is a map of New York City. Oops. And these are different communities within the city. And each of these green communities is represented by these green dots, purple community, there, pink communities, etc. And the lines between these communities indicate when someone has had group sex or lived in both of these. So the fact that there's a line between these two means that there's at least one person who lived here and had sex there, or lived here and had sex there, or had sex at both places. And what that does is it helps us understand which places are central in the network and therefore which places we should focus resources in order to break down the flow of transmission across the entire city. Another way of showing that idea is to divide up the city into groups that are more connected within the group of communities than between this group and say that pink group. And what that allows is when you are in the middle of an outbreak, you have a sense that, okay, we should think about the city as 4 or 5 different cities. And we know that if there's an outbreak in the purple region, it's going to kind of quickly follow to these other places here and not necessarily quickly kind of follow to these places here, because these purple ones are more closely connected to each other in terms of having people in common that have had sex in those communities than if you compare purple communities to pink communities. So these data were kind of designed to help us think through a rapid response, but equally well can help us to understand how you most effectively intervene with, for example, PrEP, by targeting the locations and the kind of subgroups of people who tend to connect people across different subgroups and locations in the city. So a lot of that was about where people live and have sex, but another thing to kind of that came out of the study is that you can look at where people, so this is where people live and this is where people reported having had group sex. These look different by race, but where people had group sex, what tended to be concentrated and tended to be similar across different groups. One kind of implication of that is these maps, unlike the previous maps I showed, answer the question, where do I have to go to reach the first third of each of these three groups, the second third, and the last third? And the first third is the places where most group sex happens. So what this shows is if we camped out at these two neighborhoods, we would reach the first third of Black people, the first third of Latinx people, and almost the first third of white people. To reach the second third of each of these groups, though, we would have to go to a different set of communities for different subgroups. So you can have a strategy for these two areas to reach kind of people who are having group sex across these different racial groups. But to reach the second third, you have to have a strategy that is specific to Black, Latinx, and white people. So again, to combat these disparities, you need to have an analysis within each of the subgroups, not just across all the subgroups. And then finally, the kind of intervention that we can create from these data is complicated by the fact that I just said most group sex happens in residences rather than public sex venues. If they happen in residences, then how do you intervene in such a big city? Well, in New York City, most people use the subway. So the subway system is kind of like a place which geographically focuses people. And the point of this slide is to say we could intervene even knowing that people are having group sex in the residences by having interventions in subway stations that are close to those residences or close to the places where people have group sex. And kind of a complement of subway stations you would need to be at in order to reach the first and second third of people are also different by racial groups. So there are some subway stations that would serve multiple racial groups. There's some subway stations that would serve only some subset. Sorry, there's some subset of subway stations that will serve a specific racial group. So that's it. I look forward to discussion. I am excited to be with you all and to talk further.
Yes, thank you so much. Quick question, I think is perfect before we segue into the Q&A. Someone wants you to clarify what is meant by group sex. So if someone only have one sex with one person in a given community, was it not included? Or only sex with more than one person?
It's a good question. So by group, we asked people whether they've had sex with more than one person or in a congregate setting. So that's group sex. If someone had hooked up with one person, they wouldn't have told us where that they hooked up with that person in the city. They would have only told us about their group sex. But because we use where people live and where they'd had sex, some of the one-on-one encounters will be captured by where people live. A huge chunk of the survey respondents that we had in our study came through Grindr ads. So these are people who are hooking up probably close to their homes, as well as maybe close to work or between work and home. So that question is useful because it points out a limitation. We really were just looking at group sex for the pictures that I showed, but the fact that we included where people lived likely captures a good proportion of the one-on-one sex that people would kind of initiate using Grindr.
Thank you. You're muted, Michael.
I'm sorry. I think that was the last. So do we want to go ahead and jump into the panel discussion?
Yes, but before we get started, we quickly wanted Rico to share his experience with being diagnosed with Mpox and how, and that then segue into our including the Q&A section. So Rico, do you mind introducing yourself and just telling us about your experience?
Abraham. Yes. Hi, y'all. I'm Rico from Atlanta, Georgia. I was diagnosed with monkeypox in August of last year. Prior to that, in July, I did have COVID 2 weeks before I got my monkeypox diagnosis, which was crazy to me. But when I did realize I had symptoms of monkeypox, I was already too late. I had just gotten my first vaccine a few days before that, and I noticed some pimples that were on my face that were not there before. I took it a little lightly at first, but I still was a bit precautious just because of what was going on at that time period. So I stayed to myself for a little while before I went to the emergency department to get tested for it. They did swab my lesions and they did come back positive. So I started to experience symptoms right before I got my positive results. My first ER visit I went to after I got those results, I had a 104.4 fever. They sent me home, basically. They told me everything was okay. That's a viral infection. It has to do with sting and... I'm sorry, I heard something.
Can everyone please mute their mics?
Okay. So I went to the emergency department after I got my diagnosis since I had a fever of 100.4, which was abnormally high and it's uncontrolled by ibuprofen and Tylenol, as I was told by my doctors. But they sent me home and told me to hydrate, to make sure that I just stay away from people. I'm not supposed to be leaving the house, all that stuff. Well, I did contact my doctor shortly thereafter, my primary. And when I spoke with him about my diagnosis that I received, he was actually able to put it up on my chart. We discussed TPOX. At this point in time, my lesions were still kind of small. The only significant thing that I had that was unbearable was the fevers and unable to sleep that well because of that. He told me he could get me the prescription for the TPOX. As we discussed that, he was leaving that day or something of that matter. So it was up to an on-call physician to do, I'm assuming, some paperwork for the CDC to list my symptoms and, you know, how do I qualify for this? It was a list of things he tried to explain. The on-call doctor called me that evening and told me no, because I didn't have enough symptoms. I don't qualify for it. Although at the time I had the lesions, as I said before, fatigue, I couldn't go to work, of course. The fever was really getting bad. It was bad. So I felt defeated, of course, when she told me no. And my symptoms progressively got even worse. Now, the only place I did have the lesions were on my face. So now it's spreading across my face, all of my beard, and it's hurting. Now it's starting to bother me. Still no help. Also, too, my throat began to swell up and I developed thrush. I couldn't eat food. I did end up going back to the emergency department. Now, this is the third time I've gone. When I went, I expressed that I was trying to sleep and I felt like at some point at night, I was losing my breath. I couldn't sleep laying down or at an angle. I had to sleep sitting up. The fever wasn't changing. Now I can't even take Tylenol, ibuprofen because it hurts to swallow. The list goes on. This particular doctor at this emergency department told me that I was just overreacting. I should go back home, and this is just what monkeypox does. Well, prior to her discharging me, my heart raced up to 210 beats per minute. And that is when they diagnosed me with SVT, which is supraventricular tachycardia. Well, they gave me adenosine to stop the heart rate, bring the heart back down to normal. And they discharged me and sent me home. well, there was one more emergency room trip. So the last trip I did take after that, I told myself I was going to advocate for me because I am in this field. I know what's going on. There's a lot of secondary infections, especially since I just come off of one massive illness to the other. My skin is smelling of death, if you will. I'll just be honest and say that. And I feel like I've developed cellulitis. On top of, I know this is thrush in my mouth and you're letting me go home without any type of antifungal or anything. Well, I went back to the emergency department and they did not want me to go to the back to even speak to me. It was more like, oh, that's that guy again with the monkeypox. He shouldn't be out here. But I spoke for myself. I'm not leaving until we get me some antibiotics for my cellulitis in my face. My fever's still not changing. I cannot swallow any Tylenol, ibuprofen, and it wasn't working anyway. I need antifungal for my throat as well. Maybe that would help me swallow medications if I had that along with steroids as well. And once I sat there and I would not let up off of them, they gave me what I asked for. They gave me the antibiotics. They gave me the antifungals. They gave me steroids. 3 days later, my fever was gone. My face started clearing up. As well, it started to scab over rather. So, that's that phase where now we're getting somewhere. And I got a little more energy back. I was able to swallow water again, pretty much, take pill form medications if I needed to. All that had changed. But I had to go through all of that. And even down to when I expressed, even at the emergency department, I talked to them about the TPOX. They told me that I wouldn't be able to get that. I'm assuming they saw a notation on my chart as well too about me asking and them saying they weren't going to do it. But it was weird for me because I saw many Caucasian men who had lesser symptoms than me that had been prescribed TPOX. So that was pretty much my experience with with the Mpox. And it was what I take from that is it taught me that from now on, I want to speak to people to let them know to advocate for yourself. If you know that you're going through this, go speak for yourself. Do research, ask questions, whatever you have to do. But a lot of the times you can't be left in the dark. A lot of people don't want to take care of you, but you might have to be the reason that you save your own life.
Thank you so much, Rico. And I am literally so upset that our healthcare system failed you. And I'm so glad that you were able to speak up for yourself and you were able to advocate because unfortunately that may be the reality for a lot of other Black queer men who may experience Mpox. So thank you for sharing. And I definitely want you to—
one more thing to Abraham. I meant to mention this. I think it was Mr. Greg that mentioned something about risks for cardiovascular disease once you have following monkeypox or COVID, etc. They tried to tell me that I had already had had a heart condition. And I was referred to a cardiologist after all of this. And because of the SVT I ran when I was in the hospital. And I have been following up with a cardiologist now for almost a year, and they haven't done anything. I've done multiple tests. They had me to take a beta blocker originally, and then she pulled me off of it because it was bottling my heart rate out. Just been monitoring every few months, going to see her. No SVT, no XPs every time I go in, nothing. It was just when I had that issue with monkeypox.
Okay. Oh my! Everyone in the comment is saying how upset they are with this, and I know that I speak for everyone on this call. This is absolutely unacceptable, and but I would definitely want you to stick around because I'm sure there will be other questions for you, and we will now segue into our Q&A segment. And Michael, did you want to kick us off with some questions?
Just in the spirit of PrEP in Black America, well, first let me say thank you, Rico, for sharing your story as well. And I want to go to one of the questions I saw in the chat. We did have some preliminary questions that we had come up with. But I think in the spirit of PrEP in Black America, where we want to be solution oriented and want to talk about how we can take care of the health of our community and take care of each other, I want to go to a question that was in the chat about 20 minutes ago. Clear data regarding disparities, and this is coming from Wakefield. Clear data regarding disparities, knowledge that vaccines and behavior change work. What are we willing to do to impact on Black and Latino for impact on Black and Latino men? What if every HIV and an HIV epidemic organization prioritized Mpox vaccination and HIV testing for the summer? or if we had printed material at our and for gay pride events, and why are we not, what more can we do to actually see impact in the community? Thank you, Wakefield, for that question. And if anybody wants to chime in on just what can we do as a community, especially when we look at some of the organizations that work directly with the Black queer community or Black-led organizations, what are some things that we can do?
Yeah, I can jump in really quickly with just a couple of things. I mean, Wakefield, thank you for the question, and thank you for going, right to what are some of the solutions and things that we should be thinking about. Some of this is already taking place. Before the summer even started, CDC and the government and HHS, Dimitri and others were working with Black Gay Pride events to make sure that Mpox doses were available for Pride in many different cities. They were already putting together toolkits. CDC has a really nice toolkit that they put together before Pride to discuss some of the issues around Mpox, some of the messaging around Mpox, things that people should have in their hands to really make sure that this is something that they understand that's still taking place and is still an issue for us. So I think that there has been a lot of work into that. What I'm curious about is evaluating all of this work that's been done to really stem another outbreak from Mpox. Thankfully we haven't heard of another outbreak like we heard in Chicago at the beginning of the summer, but we're still not out of the summer yet. And there's still an awful lot of work that needs to be done to make sure that we don't have another outbreak of people who are either reinfected with Mpox or people who are getting Mpox despite being vaccinated. And that's where, I'm curious to see what type of work is being done there. But up until this point, a lot of the work that CDC, the White House, and others have been able to galvanize has really gone towards Wakefield's question and really making sure that there is a concerted effort to address Mpox in communities of color.
Yeah, I would add that it's important for organizations to kind of have a plan for if things escalate as they did last year. So being clear about referral pathways for treatment, how they're going to contribute to closing the gap between vaccination among white people and vaccination among people of color, particularly Black people. I think organizations kind of should assume that the health system, that the formal health system is not going to fix that problem for us. We need to do it from the side of civil society.
You're muted, Michael.
Thank you. And I also want to just jump in real quick to introduce, we do want to thank Dr. Dimitri Daskalakis and Ian Kraklak from CDC, who have both joined our call today. And Dr. Dimitri just dropped some CDC links for event organizers who want to share information about Mpox. And I'd also just like to throw out a question as far as if we can get just, as we're trying to get our community to get vaccinated, and Dr. Ian or Dr. Dimitri can answer this question, or any of our panelists, as what are some talking points for people who don't believe that the vaccine is effective, or if they don't believe that it works, or they don't believe that it's safe? If we're talking to our community members, our peers, what are just some talking points? Because we can't always like pull out our presentations and books and all of those things when you're talking to somebody at the bar or the bathhouse or at a party or out to dinner with your friends. So like, what are some ways that we can actually present and let people know that this vaccine works and that it's safe and that it's important that our community get vaccinated if you haven't gotten both doses already?
You're muted. Or is he not muted? It doesn't show that he is.
That fixed it. I was double muted.
Okay.
Sorry about that. So Michael Abraham, thank you so much for having us on. Calypso and Greg, thanks for great presentations. Rico, thanks for sharing your experience. Again, I think we're all angry for you, so thank you for raising that up to really make sure that we try to do better where we need to do better. So first, I want to start with all of that. But just briefly, I'll start and I'll hand it off to Ian. I think Ian is the VE expert here. But I think in terms of messaging, I think there's one really consistent message, which is 0 doses of vaccine provide 0 protection, 1 dose provides some, and second is the best that we can do with the vaccine. So that's like the really simple talking point. And I think Greg covered it in a lot of detail in terms of what we see with the actual vaccine effectiveness, but then also important to say that even when the vaccine doesn't prevent Mpox infection, it seems to reduce the severity of the infection, which I think is also really important. And so there are studies that are coming out that will really indicate that it prevents hospitalization and some of the other more severe manifestations of disease. So I think that that's like a brief, the talking point is 0 does nothing, 1 does something, 2 does the most. It's not perfect, but even when it doesn't work, it seems to work to prevent severity of disease. Ian, I want to hand it off to the vaccine effectiveness expert to see if you have anything to add or agree.
Thanks, Dimitri. No, I think you covered it perfectly in that, the most important thing is to get at least 1 dose of the vaccine, and that, that the studies have shown that the vaccine is safe and effective, and unless you get a dose, you're not going to be protected. So,
and thank you, Ian and Dr. Dimitri. I have a question related to Greg's presentation around STIs and thinking from a community standpoint around like DoxyPEP. Is there any correlation between a person who may take DoxyPEP and their reducing their chance of getting Mpox? Because I do know that people are now talking about DoxyPEP and recognizing that STIs was a direct correlation to Mpox. So just want to go ahead and start that conversation now, because I know many people may begin thinking, hey, if I take DoxyPEP, will that prevent me from getting Mpox when we think of group sex?
So this is Ian. So in terms of protecting yourself against Mpox disease, I haven't seen any data that suggests that. And I would just reiterate that vaccination is the most effective way to protect yourself against Mpox disease.
I was going to follow up really quick and just say, and Greg, I think this was the question went to you, but I'll start by saying, I think we also don't know who's on DoxyPEP in a sort of systematic kind of way. So I think that definitely it will learn more as we go, but I think also just from the perspective of the biology, like we don't expect that the doxycycline, that antibiotic, should have activity against Mpox. Though I think, as Greg brought up, like, is there some interaction between STI and Mpox and potentially getting Mpox? I think that we don't know either. So I think that those are 2 really open questions. And Greg, I'm not sure if you have something to add there too.
No, exactly what Ian had mentioned is that, it's still too early. We haven't seen DoxyPEP really disseminated in many jurisdictions, really apart from San Francisco. San Francisco is doing an amazing job of getting DoxyPEP out as quickly as possible. I haven't seen what New York is doing, but I'm pretty sure that they're doing it as well. But really the primary way that you can prevent infection is, at least getting 1 dose of the vaccine, even though we do see these, associations between STI and Mpox.
Thank you.
One interesting thing just to add for DoxyPEP, that syndemic package, like the HIV, STI, not living in isolation with Mpox. I think DC did something really interesting during their Black Pride, which is they actually did give out DoxyPEP at their wellness pavilion, which I think is really interesting and great to see. And CDC guidance is coming out for DoxyPEP this summer. I know that that's come up a bunch, so we expect that to land at some point soon.
Thank you. And that's innovative, giving it out at Pride. That's very innovative. Hopefully more organizations will follow suit once we get those guidelines. All right. So I did have a question. I'm sorry, go ahead.
No, go ahead, Michael. Go. No.
I also had a question for Calypso. What is the next Respond MI study in terms of applying your key findings to further advocacy around Mpox vaccinations, treatments, and public health interventions in NYC, nationally, and globally? And are there any lessons learned in terms of community engagement in that research that you're able to share based on your team's experience launching a study of this kind?
We're actually collecting another wave of data right now to follow up on last year's data. And we are working with the City of New York to both disseminate our findings from last year within the folks who work in public health in the city. And this other project of just kind of coming up with an emergency response plan that involves civil society and has clear roles and has kind of a clear understanding of what to do when things like this come up, so that you don't have to make kind of ad hoc arrangements like the coordination call that we had. So I think the efforts right now are to kind of learn from that response. In terms of lessons from kind of doing this kind of community-based or community-led research, I would say that one thing that people might find surprising is that it is possible to engage deeply and quickly. We went from having an idea to having data for analysis in 6 months. And I think that's something that bigger studies that are much better resourced than us often don't manage to do. And we have a model for doing it. We did it. And so that is another major lesson that I think will be useful for folks going forward, is that you don't have to kind of build a complicated machinery for consultation. And also you can't use the fact of urgency as an excuse not to do the consultation.
Thank you. Thank you. And I'll pivot to Abraham. Do you have any questions?
Yes, my question is for Rico. Rico, how has your personal experience with Mpox been received amongst peers, and how did you communicate that amongst them around your experience?
It really did. It motivated a lot of people to go be vaccinated around that time, actually. When a lot of my peers and some of my friends as well saw that I just gotten my vaccine and I, pretty much had the infection already, and they watched me go from stage to stage with this disease, and they didn't want that for themselves. So they were like, okay, so I need resources. So I was sitting here at home day in and day out because I couldn't go anywhere. And I was on Twitter catching these links for Fulton County or Clayton County or Gwinnett County, sending it to them so they could register to become vaccinated. And I also do keep them abreast of other types of protection, like it's not just a sexual transmitted disease as well, possibly. And you want to be careful. If you're working in healthcare, wear your PPE. Be mindful of who you're touching. As far as when it comes to with you and your sexual partner, pay attention to your bodies. Notice the small little changes. That could be something big and you just don't know it. So before you interact with people, you might want to just talk about it and be open about it. Have you been vaccinated? I haven't been vaccinated. Have you, have that conversation, motivate your partners to get vaccinated as well. Because if you're both vaccinated, that's going to pretty much decrease any risk, massive risks for transmission. So I've been really on my peers about that.
Thank you, Rico. I have a follow-up question for you. Thinking about the number of people who don't go back for their second dose, have you heard anything from your peers around the quality of experience when getting vaccinated? I think that's an important thing to talk about. Like, how is it getting vaccinated? Did they feel respected, or have you heard any talks around that?
I know that they had a hard time getting vaccines initially. Not so much now anymore, but a lot of them did get the first vaccine, and the second vaccine was very much so hard to get, and they had to get, I believe they got 2 different types of vaccines, if I'm not mistaken, around that time period. They got one injection in the arm at one point, and the intradermal was the second one they received. A lot of them were actually turned away from other places because they didn't have enough vaccines, but then that was me again, researching, hey, you can go here and get some vaccinations here. So a lot of them did run into a couple of things to discourage them or make them want to give up. But again, they saw what I went through and they were like, no, we're not going to settle for that. We're going to go forward and make our way.
And I have one more question for you, but we're at time. Mike, do you want to close us out, or
Yes,
okay.
I just dropped Abraham and my contact information. So definitely, if you want to keep this conversation going and learn more about what's going on with PrEP in Black America, definitely visit us on social media as well as on our website. And you can email me or Abraham. Also, just want to plug it again for those who weren't on the call. PrEP for All, I will be I'm going to send out the link with the recording of the webinar to everyone who registered, as well as a survey. We are, with the support from AMFAR, we do have a survey where we want to continue to get people's we do have a survey that'll be coming out in the next several days, where we do want to get people who are advocates working in the field or communities impacted by Mpox. Just get your insight so that we can know how we need to respond to future outbreaks and epidemics, especially those where we want to see more equity amongst the Black LGBTQ communities as well. So definitely keep an eye out for that survey, as well as the recording of this webinar that will be shared on YouTube and across our social media channels. And we encourage everyone to share all of the information that you learned today from the webinar as well. And I'll go ahead and pivot one more time to Abraham to round us out with that final question.
Yes, I see Jeremiah has his hand up. So go ahead, Jeremiah.
So sorry to interject. And one more thing is, if anyone's interested in being interviewed more in depth in terms of the activist and broader community response on Mpox last year, you can email Michael. We could really use some people to have some more in-depth conversations about that Mpox experience. And so you have his email in the chat. But anyway, I'll give it back to you guys. Thank you so much.
No, thank you, Jeremiah. I just want to thank all the panelists, especially you, Rico, for being so candid about your experience. And I think that this just highlighted the inequities that a lot of us already knew were in our healthcare system. So we have a lot of advocacy to do and also work. So thank you all again. I hope you enjoy the rest of your day. I think that was great. Oh, girl, bitch. Okay, let me.